Okay, hello everyone.
Okay, hello everyone.
There is some echoes, please mute.
There is some echoes, please.
Are you opening from
Oh,
another device, Mahmoud?
no, just one device. It is okay now.
Okay, I think you are good to.
Okay, our case is 57 years old, male patient, working as a teacher, no special habits of medical importance, no past history or family history of medical importance. He presented with 5 days history of sudden onset and gradually increasing swelling of both lower limbs and scrotal swelling. This was associated with diarrhea and vomiting. The condition was preceded by fever and flu symptoms a few days earlier. Drug history was irrelevant. On examination, the patient had low-grade fever. The pulse was 100 beats per minute, regular pulse. Blood pressure was high, 200 over 100. Lower limb edema up to anterior abdominal wall with abdominal enlargement and positive shifting dullness and hydrocele. On investigation, laboratory investigations, urine analysis showed 3 plus proteinuria, RBCs 15 to 20 per high power field. Serum creatinine was 5.4 milligram per deciliter. Creatinine clearance was 5 ml per minute. Albumin was 3.1 milligram per deciliter, and when repeated after a few days was 2.6 milligram per deciliter. 24-hour urinary protein was 12 gram per day. Cholesterol was 278 milligram per deciliter, and triglycerides was 127 milligram per deciliter. CRP was 8, ESR was 30, white blood cells was 10,000, hemoglobin was 14.8 milligram per deciliter, platelet was 241,000, INR was 1, bilirubin liver enzymes all were normal. Hemoglobin A1C was 5.1%. ABG showed metabolic acidosis. pH was 7.3. Bicarbonate was 14.6 milliequivalent per liter. BCO was 29.4 millimeter mercury. Sodium was 133, and the potassium was 5.3 milliequivalent per liter. Autoimmune markers were done. ANA and double-strand DNA, C3, C4, ANC B, and C all were negative. Virology serology for HCV, HBV, and HIV were all negative, but the patient was tested positive for COVID-19. Ultrasound, pelvic abdominal ultrasound was done. The liver was average in size and mild fatty, with patent portal vein and normal in diameter, average size spleen, normal size and echogenicity of both kidneys, but the patient had moderate ascites. Scrotal ultrasound also was done, which showed scrotal edema and hydrocele. Initial management, the patient was started on empirical steroid, pulse steroid, based on clinical suspicion of RBGN, and there was no response, and serum creatinine increased to 10.6 milligram per deciliter, and the patient started hemodialysis. Renal biopsy was done. The biopsy showed 11 glomeruli of 4 segmental sclerosis, segmental glomerulosclerosis, as in this picture, with adhesion to the Bowman's capsule. In this picture, there is focal segmental glomerulosclerosis. In this picture also there is some segmental sclerosis with adhesion to the Bowman's capsule in this slide with silver stain. The biopsy showed also diffuse tubular injury with tubular necrosis and shedding of the epithelial lining of the tubules. Here also there is acute tubular injury and hemoglobin casts are seen in some tubules. So there are some questions looking for answers in this patient. Is this pathology related to COVID-19 infection? Any recommendation to continue steroid therapy or add another immunosuppressive therapy? Would you request any further investigations for this patient? And thank you.
So you're talking about someone who has COVID-19, and I just missed this part. So as far as the pathology, was it called collapsing or tip lesion? How was
No, it is not. It was not otherwise specified.
not otherwise specified?
Yes.
So most of the COVID-19 related FSGS were mainly presented with a collapsing form. I've treated few of them, and there is case series that describe these entities. It's universal that these patients are ApoL1 related. So what we have there, as you know, the ApoL1 high-risk allele, which tend to be of patients of African ancestry, this ApoL1 risk allele does form this protein in the podocyte. And this protein in the podocyte is, whenever we have a mutation in this protein in the podocyte, what happens is that under interferon stimulation, so anytime you have a viral illness, that will increase your interferon, COVID-19 being CMV, EBV, parvovirus, what will happen, a viral illness will increase your interferon, and that will lead to an increased expression of your ApoL1 gene. When you have increased expression of your ApoL1 gene, you have podocyte injury. So that's what we know about ApoL1 and podocyte injury and the virus. So really, you have a virus, you have a genetic predisposition, you have the viral etiology, they have a virus that activate and make the interferon increase, and increased interferon will increase the expression of this bad gene, and the bad gene will cause the podocyte injury. So theoretically, when you talk about genetic FSGS, you think, genetic, I'm not going to give immunosuppression. But really here, what you're talking about a viral trigger of a genetic mutation. So that's why, in general, in these patients, we still treat them with immunosuppression, although they are COVID-related. The results are very heterogeneous. Some patients that were described had very, very good outcomes. Some other patients had progressed to dialysis. So if I have the option, I would just send specifically for ApoL1 risk allele to see if really it's COVID-related. Because if you don't have ApoL1 risk allele there, it could be just two not related things. COVID is so prevalent, and you have FSGS, and maybe the FSGS has nothing to do with the COVID. That's one thing for the diagnosis. And for the treatment, I think this patient has a sudden onset nephrotic syndrome, will require immunosuppression to give him a chance. I will just give him a high-dose immunosuppression for like 4 to 8 weeks, and then taper it over 6 months and hope for the best for him. He looks good, in good shape to take immunosuppression. Do you agree on this, Dr. Sabri?
Professor Abdullah, I'm just asking about if you are doing gene mutation routinely for CoVAN. Are you doing it routinely, looking for the mutation?
Whenever we have COVID-19 related FSGS, it does help to have the ApoL1 risk allele. So we send just the ApoL1 for ApoL1 risk allele. So if you have the high risk mutation.
Do you look for tuberoreticular inclusions in this patient? Is it one of diagnostic? It has a diagnostic implication. It has a rule in diagnosis, because as you said, the viral released induced the increase in interferon might we can find it in any other infection as well. I mean the tuberoreticular inclusions. Did you rely on its presence in the biopsy to confirm the diagnosis?
No, that was not consistently found on all the biopsies. Finding tuberoreticular inclusion to classify these patients as interferon related or not interferon related. No, that's not something that's been consistently found. That's when it comes to ApoL1 and the pathogenesis, we think it does include interferon, but we're not seeing consistently these tuberoreticular inclusion for these patients.
Okay, what about the viral particles? You know that it has been seen in, I think, in one series only in the postmortem biopsy, and it might be as you got it. It may be just an artifact, postmortem artifact, and I think most of the biopsy included from CoVAN did not confirm the presence of antigen particles. So, what's your comment about this?
Yeah, there was a lot of discussion early on. As you know, when COVID came in, we had so so much data being published without like editorial, like extensive editorial review, and people were just commenting a lot about the fact that maybe some of what was published was not 100% true. So bottom line, just they were talking about this Quran, or that's this that looks little tage can on the biopsy. They were thinking about this being a sign of the coronavirus inside the podocyte, but we feel like it's more the mitochondria that's actually swollen mitochondria that's there, not the virus itself. Some people describe also the virus present in the urine, but we do not have data to support the fact that actually the virus directly affects the podocyte. We think it's through the interferon, stimulation of the interferon secretion, that it does affect the podocyte, as far as we know right now. But you're right, initially we did have some report of potentially the virus in the kidney. Yeah.
Okay, of course, I agree with you that the use of immunosuppression is special steroid, and the most interesting in this case, actually, which is reported in other cases of COVID, the mild or even absence of respiratory symptoms of COVID infection, which cope with the renal involvement. I mean, most cases have a little or no respiratory symptoms.
I have a question, please.
Yeah, please go on.
If this patient presented with in failure, so if this patient passed to dialysis dependency, for how long you will maintain the immune suppression?
It's a some benefit discussion, but just I will give him a full course of 6 months. So I will just do like at least 8 weeks of the high dose, the 1 milligram per kg, and then taper it down. He looks like 54. I'm not sure about his body habits, his risk of metabolic syndrome. Maybe I will just be a little bit more conservative there. But as long as he can take it, I think he deserves this option. If the patient starts to respond very well, what I will do is just I will taper the steroid very quickly and add a calcineurin inhibitor. It does help whenever you add calcineurin inhibitor to be able to taper the steroid much, much faster. Of course, with a creatinine of 12, you cannot do it right now. I have a question for, I'm not sure in the panel, maybe Dr. Sabri, you would tell me. Do you know of any data on the epidemiology of APOL1 in like Egyptian population? Because we talk about as being very prevalent in sub-Sahara Africa. I'm not sure how prevalent is it in Egypt specifically.
Unfortunately, I don't have enough data. You know, the genetic testing actually are a little bit missed in Egypt. We have shortage in genetic testing. So unfortunately, I don't have any updated data about this. As you said, it's common for those who have African descent from sub-Sahara, but in Egypt, I don't have enough data about the prevalence of this gene mutation. I don't know if any of the audience or my colleagues have any data. I'm really sorry to disappoint you, but really I don't have any data about this. As I told you, we have some investigation, especially the genetic testing.
If you allowed me, Dr. Ala.
Yeah, please.
Yes.
This
yes.
is Mahmoud?
Yes, sir.
This is Mahmoud,
yes,
sir?
sir.
Yeah, Mahmoud.
Dr. Abdullah, actually in our community we have a higher higher incidence of Alport syndrome, which is another gene deficiency that's related also to the pattern of focal segmental. As you know, the most common genetic deficiency or genetic disorder with genetic FSGS is the collagen mutation. So my question was, should we consider the Alport syndrome as a can be subclassified under the term genetic FSGS or not?
So it's a tricky question because collagen for associated glomerulopathy is an entity by itself. When we talk about FSGS, you're talking about a histologic lesion. So any lesion in the kidney can heal an FSGS lesion. So what you're seeing there is that since collagen 4 mutations are quite prevalent, you're seeing a lot of collagen 4 mutations that are miscategorized as being an FSGS lesion, as being an FSGS disease, where what they have is collagen 4 induced glomerulopathy with a histologic lesion of FSGS. So for me, I mean, I would just put these patients under collagen 4 associated glomerulopathy. I will not put them as being FSGS, just exactly like when you biopsy a patient with membranous nephropathy, you see few glomeruli that have FSGS. You don't call this FSGS disease, you call this membranous disease, and you do have few FSGS lesions. So I think it's just more of categorization thing, and I would like to keep the collagen 4 related or associated glomerulopathy as a separate entity, because people are looking specifically at this collagen 4 related disease, and some people are talking about potentially targeting through mRNA interference of collagen expression, targeting the specific disease with specific entities. The interesting part relating ApoL1, for example, we mentioned this, is that recently there is a company called Vertex that is developing a molecule that interfere with ApoL1 expression. So as you can see from all these discussions, we are more and more trying to subcategorize these patients to the pathogenesis and give the treatment specific on the pathogenesis. And I would like just to keep this collagen 4 outside these genetic FSGS and put them in this collagen 4 associated glomerulopathy. I'm not sure if I asked you a question.
Sure. Thank you, Dr. Abdullah. Thank you.
About APOL1 gene, it prevents and protects African from trypanosomiasis, and unfortunately the gene mutation, which is in high-risk patient, I mean mutation for G1, G1, G2, G2, or G2, G1, G2, it carries the hazards of development of Covan, especially collapsing nephropathy. Am I right, Professor Abdullah?
Yeah, you're 100% correct. It's something that it took, like historically was an advantage for these patients, but unfortunately put them at high risk now for kidney disease. Unfortunately, it does prevent you from infection. Something similar to malaria too.
Yeah, thanks.
And, SS and sickle cell disease.
Okay, so we have
Mansour, do we have any question for? Yeah, please go on, Mama.
We have one question in the chat box from Dr. Sarah. So she had a question regarding the case biopsy. She said, is it consistent with RBGN or it is a typical nephrotic syndrome? Because the patient presented with RBGN like as progressive decline in kidney function, but the kidney only has FSGS.
So I'll take this question unless I'm not seeing the gentleman who presented the case if he wants to. Dr.
Mahmoud, yeah, I think Mahmoud was
Nagib.
Yeah.
If you would like to answer.
Yes.
You want to answer this question?
Yes, I think the deterioration in renal function may also be related to the diffuse tubular injury and the necrosis that was present also in the biopsy, not only the FSGS. Not only the FSGS.
Just to
Mahmoud, the different. Yeah.
I can show. Yes.
Yeah. When we talk about RPGN, is rapidly progressive glomerulonephritis. So you need to have the nephritic syndrome plus acute kidney injury. Here you had the nephrotic syndrome plus acute kidney injury. So sometimes it's hard clinically to differentiate between the two, and you would think that this patient has RPGN, but when you did the biopsy, you did not see any inflammation there. This is nephrotic syndrome plus acute kidney injury, which is not common presentation, because usually nephrotic syndrome do not have acute kidney injury, but it can happen, like you said, either because this patient had severe interstitial fibrosis, and sometimes what you see acute tubular necrosis, because these patients can be intravascular depleted because of the hypoalbuminemia and can have hyperperfusion of their kidney. So they will have the nephrotic syndrome plus acute tubular necrosis and this entity. So no, it's not an RPGN because you don't have nephritic.
Yes, thank you.
Okay, I think we should move to the next speaker. The next speaker will be Dr. Dalia Yunus. Dr. Dalia is a